Chronic mental illness, homelessness, and substance abuse have been identified as the top major health problems in Fairfield County.
Our guests on this week's Health Talk will talk about a community approach to improve health outcomes for those individuals with these complex chronic conditions.
Stay tuned. Vicki and I are up next.
Hi, I'm Dr. Vicki Smeaton.
And I'm Dr. Eric Mazer. Joining us today to discuss local efforts to address chronic mental illness and homelessness, as I mentioned, and substance abuse are Rowena Bergbins and Dr. Catherine, also known as Tate by her friends, Michael.
Rowena is Vice President of Clinical Integration and Population Health for Western Connecticut Health Network, and Tate is a practicing psychiatrist and also a consultant for Western Connecticut Health Network.
You two have combined the longest titles of anybody we've ever had on the show.
And we're very happy to have you.
Yes.
Very good job.
And Vicki made it right all through it all.
We do have a very serious topic at hand. Obviously, mental illness is something that plagues not only Fairfield County, but across the board, nationwide. There are a lot of efforts and a lot of discussions recently. Where are we, Tate, in the 21st century with mental illness?
And how did we get here?
Right.
How did we get to this point?
I think it's an interesting story to think about how we got where we are. And if you look back there, we've kind of come full circle, because in the 1800s we had a lot of mentally ill people in jails. And then over the course of the 1900s,
That was just to get them out of society.
To get them out of society, they were put away. And then we began to build state hospitals, and a lot of the mentally ill, the more chronically mentally ill, were in state hospitals until the 1950s, when deinstitutionalization began. And between the 1950s and now, we've really seen 92% effective discharge rate from state hospitals.
Now,
Wow,
was it because the drugs or the management changed and allowed these people, the mentally ill, to live successfully in society? Or was it a financial decision? How did all this happen?
Well, I think it did begin with the discovery of Thorazine in 1955, but it was also a program of Kennedy's to move people into the community, which was a good idea if you had the community supports to provide care for these people.
But that's what we're finding, Rowena, that we don't actually have the community supports. So these people are in the general population, and while that's a good thing, it's not such a good thing because they're not getting the help they need out in the community.
That's correct. So the original thought was discharge people out into the communities with the supports that they need in order to live successfully out into the community, because nobody really wants to live inside of a hospital walls.
Of course not.
And at the time, there was a lot of funding provided for that transition, but over the years, for a variety of reasons, that funding dissipated. So now you're having people who are discharged. Well, you were having people discharged, and now the services aren't available for them. In addition to that, you had the hospitals closing, so there was no place for them to go in the first place. So we really find ourselves in a position where some of the folks that were discharged into the community are doing fine. They had the social supports, the family supports, but about 50% are left to really fend for themselves.
But what happens to these people?
Yeah, I was just going to ask
Where do
exactly
they
that
end
question.
up?
So
Right.
who are these people in our midst? I know a lot of the homeless people are, in fact,
Right. And
psychiatrically ill, mentally ill, but we see them all the time.
That's exactly right. And if you walk around the larger cities, many of the homeless people you'll see actually may have a chronic mental illness. Many of them have schizophrenia, and many we're putting people with mental illness back in jails again. So there's a large number of people with mental illness and substance abuse who are in jails.
So these are people who use drugs and are convicted of drug use, and that's what gets them into the jail?
That may be, or they may be doing something to pay for their drug habit, or because of their mental illness, they may be confused and may be trespassing, or may just not be able to stay in treatment and commit crimes because they really can't tell right from wrong if they're that ill.
So we've really gone full circle, is what it sounds like.
It does, and maybe we haven't come all the way back around where most mentally ill people are in jails, but many are, and it's unfortunate.
Are there services in jail to help people who are mentally ill?
There is some treatment in jails, but it's not, not very accessible, and it certainly isn't what you might, it's not the full range of care you would want to provide. You might be able to give medications, but you're not really able to do the full service group therapy, treatment of the substance abuse kind of issue. I mean, they're not using because they're in jail, but they're also not being treated.
Right. So Rowena, what is our responsibility as a society, as a health system, as healthcare providers? How do we identify? I mean, like Eric said, we see these people all the time. They're on the street. Somebody might be looking disoriented, talking to themselves. But how do we get them? How do we reach them? How do we get in touch with them?
So I think that's a really good question, because we think about caring for these individuals like that's somebody else's problem. So how do the
Right.
healthcare providers deal with them? I think what we need to first is open up the dialogue, because there's such stigma tied to mental health and substance abuse
Yes.
issues. And you go to a dinner party and people will talk about, oh, my hernia or my headache, but nobody says, I'm really mentally ill, or I'm dealing with a
Or they
with a
won't
problem.
be invited back for the next dinner party.
That's correct. So,
Right.
so I think as a society, we really need to start having a different dialogue, because once you start taking away some of the stigma, then people who are suffering in silence will feel more comfortable finding treatment. We will find more dollars than allocated
Right.
to the treatment for individuals who are suffering from these illnesses, and we can start having a different approach, right? So. I really do believe it's a cultural change that needs to happen. But in terms of the provider organizations, you're going to hear about different avenues and different approaches that we're taking as a local community in order to help individuals with these
Because
conditions.
one of the consequences of mental illness is, for many of those patients or people, they become high users of the conventional medical services. They disproportionately use the emergency room, who can't deal with a chronic mental illness.
Yeah.
Maybe you could say a little bit about that, because it really has been shown that so much of our resources are inadvertently being invested in the wrong places for caring for some of
Well,
these folks.
I think there's a couple of things going on there, right? Yes, you're correct. There's an inordinate amount of resources being distributed or released in a really inefficient manner, right? So nobody goes to the emergency room to get comprehensive chronic care management.
Right.
It's supposed to be for an acute care episode, but we find people are using the emergency department in a chronic manner.
And it's not only people, the police use the emergency room, the fire,
Right.
and even some of the patients use the emergency room on a cold night to get out of the cold. So it's sort of the emergency room has become the
It's
the
become the
dumping
safety
ground.
net.
Yeah.
It's
That's
become
right.
the safety net for
That's
society.
right.
Yeah.
And so we, as a culture, we don't really tolerate people being intoxicated in the community anymore in the way that maybe we did in the past, and so they get brought into the emergency
Yeah,
room.
people
And
don't
then it's up
realize
to the
that
healthcare system to figure out what to
Right.
do with these individuals.
when it used to be that either drunks were allowed to sleep it off, people who were drunk, or they would be brought to a sobering tank or a jail cell where they'd sober
Yeah.
up. Now they're all brought to the emergency room.
And so we talk about the financial impacts, but also think about the emotional, societal, and the impacts to those individuals, because you're really not going to get adequate treatment in an emergency department. So we're spending an inordinate amount of money and we're not getting positive outcomes. And it's almost like, the sign of insanity, hit your head against the wall, it doesn't feel, but you keep doing it.
Right.
We seem to do that as a society. We end up, the emergency department is the catch-all, and it's not an efficient manner.
And it's not just for substance abuse. I know we focus a lot on that, and obviously that constitutes
Mental
a large
health.
segment of folks who might have comorbid mental illness.
That's
but
right.
there might be somebody who's feeling particularly anxious or unsafe or needs to
Absolutely.
reach out and doesn't quite have access
Absolutely.
to a community resource. And so, of course, like you said, the emergency room is really the
And
safety
you,
net.
as a practicing psychiatrist, I know for a long time you helped to cover the emergency room when necessary. Do you have any anecdotes or things that sort of illustrate the problem of your inability to care for somebody in that setting?
I think Vicki raised an important issue, and that's one of access. And so because we can't get people in as quickly as maybe would be best, they end up coming into the emergency room. So there are many situations in which that has happened. And in some cases, the clinics in Fairfield County that take Medicaid, for example, are so backed up that it will take 3 to 4 months
Maybe you could
to
say
get
a few
in.
words about
Yeah.
that, because I think someone at home might say, well, a lot of these folks have Medicaid. Why don't they just see a psychiatrist and get pay for it with Medicaid?
So Fairfield is in a particularly interesting situation, because not only are the Medicaid individuals not able to get access to care, there isn't a lot of access for people who have insurance either. So we really have a deficit of.
And what does that mean, Rowena?
So,
when we
so,
say there
i-
isn't access?
so if you're trying to find a therapist who will take, your
Any
health,
insurance.
any insurance,
Right.
so through your employer or your own purchased insurance, it's very difficult to find therapists.
So most or many of the psychiatric professionals in our community require
Cash.
cash. And that's the point I
Absolutely.
was trying to get to. That
Absolutely.
So
And-
even though there may be people around, it's the amount that's allocated through Medicaid or even insurance is not enough to really take care of the problem.
And if you
That's
think
correct.
about reimbursement from insurance, and this gets back to sort of what is our societal responsibility and what is the discussion,
And
right?
what do we prioritize
That's
as
right.
far as
And
what we pay for?
How do we start having the conversation that we need to reimburse providers who deliver this care in parity with medical health services? And we need to start really having that conversation because the result is we're getting what we see.
Right, because if you're not going to, as a provider, right, Tate, as a practicing psychiatrist, and not you personally, obviously, but somebody who's out in the community practicing, if they're not getting reimbursed by the insurance company in any sort of meaningful way, of course it sounds almost rational that they're going to go toward a cash-only model where they won't accept insurance at all,
That's
because
right.
otherwise they won't be able to meet their overhead and whatever their expenses are.
That's exactly right. And your issue of what our priorities are. So if you imagine what an insurance company might pay for a doctor's visit, so maybe $40 or $50, and at the same time someone might be on medications that add up to $2,000 a month.
Yeah.
So the medication, so we're really prioritizing spending a lot of money on medications and a lot less on just the human contact
Right.
that can be so helpful to people.
Maybe as a final point,
Yeah.
the medical reimbursement system is irrational in and of itself. So certain procedures, you pick one, colonoscopy, have a very high margin for hospitals and practitioners,
Right.
whereas
a
others don't.
psychiatric visit
So,
pays very poorly.
back when
That's
we were
right,
yeah.
talking about the Affordable Care Act with Jim Himes, I used to tell people you can be lucky and have a good disease like something where you need a hip replacement, or you can be unlucky and have a bad disease like mental illness.
Right.
And
That's
it's just
correct.
because of the irrationality of our healthcare system. The hospitals
Yeah,
that's
desperately want you if you need a hip replacement,
Right.
and they don't want to see you
Not
if you
so
have
much if
mental
you're-
illness.
That's right.
And I'm saying that a little facetiously, but it's a consequence of our reimbursement system.
So that's what we're looking to revamp, and I think in the
Yeah.
second segment, we're really going to touch a lot
Right, we're going
on
to come back
what
and
we're
talk
doing.
about what you guys have been doing so effectively in our communities to help bring resources to patients. So we'll be back after this short break, but stay with us. Hi, Vicki and I are back with Rowena Bergmans and Dr. Tate Michael. We're talking about community resources for mental health, and some really great things have been happening in the past couple of years. So tell us about it.
So, yeah, we have some pretty amazing programs up and running right now. It all started with a community health needs assessment. The hospital partnered with Norwalk Health Department and other health departments and social service agencies.
This is actually, to give credit, this is a Medicare required activity, isn't it?
It's under the Affordable Care Act. Hospitals need now to do a community health needs assessment every 3 years, or they run the risk of losing their nonprofit status. So we conducted that community health needs assessment, identified mental health and substance abuse as being one of the top 2 and 3 issues that are facing our community. Not unlike every other community in the
Right.
state of Connecticut or nationally, but it really highlighted and when
We make like things like cancer and heart disease. Those are obviously major health problems, but there are a lot of resources devoted to them.
That's
And
correct.
patients are able to access resources for that.
That's correct. So when we went out into the community and said to church leaders and schools and civic leaders, what's the number 1 or number 2, number 3 problems that you're facing with the communities you serve?
Mental
and it
health
was mental
came
health
up,
and substance abuse. So from that, there was the development of the community care teams, as well as developing resources for not only practitioners to go to, but also people who are utilizing the system. So Dr. Michael here is leading our efforts around the community care team, which we've been seeing just some phenomenal results
Yeah,
from.
tell us
So
about
what is that exactly, the
So
community care team?
it's a really effective form of taking care of these very vulnerable groups of people, so the people with severe mental illness, homelessness, or substance abuse. And we get together with all of the service providers in the community who
So-
would really touch that person.
So these were people that were already around in the community but were disconnected?
Yes, absolutely. And so we'll have people from the shelters there. We'll have people from the substance abuse programs, mental health programs there, hospital obviously. And we'll all be in the same room, and we will come up with care plans
So
for
you
each
talk about
individual
specific
patient.
patients.
We do.
We have some
We have some
pictures of the
pictures,
meeting,
yeah.
so let's
We'd love-
bring those up, and you could give sort of a visual help to what what you're talking about. How
Right.
often does this group meet?
So we
Here,
meet
here we are.
weekly. So this is a shot, this is zeroing in on our community care team navigator, and she's really a key person for this group.
Which one is she?
She's the one on the left. Her name is Stacy, and she contacts the provider. She will actually do outreach to the patients and go out into the community and see them.
Tate, how did you identify the top people at risk who would be addressed by this team?
So Norwalk was interesting in the way we did it. We actually, as compared to some of the other programs in the state, we also focused on homelessness as an issue, as a criterion.
Is this a normal population, number of people, normal to have sitting around the table?
Exactly. So
literally?
we'll have 20 or 25 people sitting around the room. We have some people from insurance companies there, and it's really an enthusiastic group.
And these are people from all different community agencies and places that can help, help participate in the care of that particular patient that might be discussed at that meeting.
That's
How many
right.
patients do you generally, are we talking about hundreds of patients? Are we talking about 50 patients? Just give us a sense of how, we know it's a broad problem, but in
Sure.
our community, what are we really talking about?
So this team has been up and running for about a year, a little over a year now, and we've reviewed close to 170 people.
Wow.
Wow.
So, they may not all be active at one time, but people are coming in and new people are being addressed and that
Do you
kind
come
of
up with
thing.
a care plan for those people? So you say,
We do.
here's this person, here are their problems, and then people volunteer as to how their services may be able to help them out. Is that what goes on?
That's exactly right. So, for example, someone might be homeless and abusing substances, and the view here is that you really need to provide some sort of housing before you can deal with some of the other issues.
Marina, this is a real different paradigm for healthcare, and sort of a new paradigm in that I think for ages, we were the hospital, we were the doctors, and if
Right.
people needed our help, they came to us.
But
This
now
is
we're-
really
Absolutely.
saying we need to reach out to them. Tell us about
Absolutely.
that shift.
So it's a big cultural shift. Hospitals historically, would treat somebody when they showed up at the doors.
Right.
And now we're finding that in order to be good citizens of the community, and as well as understanding what the needs are for the community, that we need to go out into the community and not wait for people to show up at the door. So if you look at the program that Tate is running, Dr. Michael's running, and others who are participating, there's only a few folks from the hospital who are actually participating in this group. It's mostly the community leaders. And what I think is really interesting is the folks that we're discussing developing these care plans for, they're touching every single one of these organizations at one time or another, or a subset of that population. It's just realizing that instead of requiring the patient to have to navigate the system and find all these different touch points, now we're actually saying, wouldn't it be a better idea to put the patient at the center, and all of these systems come together to focus in on the patient versus the other way, outward facing versus inward facing. So.
And looking at that number, 170 patients, it may not sound like an enormous number, but if you think about how many times each of those patients might access the emergency room or might have some serious adverse event out in the community, it actually adds up financially to a lot of dollars.
I think Dr. Michael can speak to that, at least the results that we've seen for this first year.
What are the results, Tate?
So we've been able to, through a lot of work of these community providers, have been able to house about 20, or at least get vouchers for about 20 people, which is big. And we've been able to link them with services that they need. and also reduce the emergency room utilization by this group by 32%.
Wow.
That's pretty significant.
You know,
So-
maybe you could say a few words about that seminal article, which people may not know about at home, but by Atul Gawande, the high utilization of health services by people that are struggling to find access points.
That's that's exactly right, and you know, it not only is it more expensive, it's not very good care.
And that's the point. Here we're
Yeah.
able to achieve something that seems incongruous, that we can give better care at a lower cost for
That's-
these patients who were getting it the wrong kind of care.
That's right. You know, and there's I'll say a word. There's an interesting program in Tennessee. Cherokee Health Systems they have an integrated model where they actually have a behavioral health consultant in the primary care offices working as a team with the primary care physician. And so the idea there is that the people will follow up with their primary care doctors where they may not ever connect
Right.
with behavioral health care.
So if
In
you
fact-
have somebody right there working,
And that's a
in
new model for
collaboration.
behavioral health too, isn't it? I've heard the word embedding a lot.
Exactly.
What are we doing then as far as I mean, this is a wonderful program, and I'm hearing that a lot of community resource organizations are involved in taking care of these individuals. What about more mental health professionals? Are they at the table also? Psychiatrists, psychologists, because we need them too, right? I mean, it's important to, you know, they're important members of the team, and we talked about lack of access earlier. Are we bringing in more psychiatrists, more folks who are willing to take insurance or see Medicaid patients who don't have other resources?
I think, you know, after being involved in this business for as long as I have, I think we're finding it's kind of hard to recruit psychiatrists. And so we're going to have to think of other models.
Okay.
The departments of psychiatry at Norwalk and Danby are very open to other models. So they're looking at embedding in where we have some work in the Cancer Center at Norwalk, and then looking at telepsychiatry at Danbury. So they're really looking at other ways.
Are any of the community health centers embedding psychiatry in their community health centers?
We are also looking at that as an option, and I think that's really exciting. I think we'll be able to make some improvements that way.
It
we're
brings
running out of-
it brings it back to a medical home model,
Yeah.
Eric, right? Because you have your primary care provider, you go to the health center, you get your diabetes care, you get your screenings, and at the same time, if you have a mental illness or a need to see that type of professional, they could also be available to you in the same place.
Exactly.
We're running out of time, but maybe I could ask Rowena, this new model of care may get more funding in the setting of accountable care organizations.
That's correct.
Right now, we're really pulling together what's available, but there isn't a lot of new dollars running into it. But just say a few words about it, because we don't have a lot of time. But
Sure.
how does this meet with the new model for accountable care of populations?
So if you think about it, if a provider organization is accountable or responsible for a defined population, both in terms of the quality and cost for that population, then they're going to try and find avenues or means to deliver that care in lower cost settings that are more efficient and more effective. So then there will be more dollars available to direct towards the services that Dr. Michael just mentioned in terms of having a behavioral health consultant embedded in primary care practices, where in the old model, that was not a reimbursable service. So if a health system was to provide that, there would be no dollars available.
So it's redirecting healthcare
That's correct.
dollars.
And then
That's
hopefully
correct.
we'll get to what then becomes a rational allocation of resources to keep people healthy or get them healthy.
And nobody wants to be in the hospital.
Right,
I
and
mean,
we've run
that's
out of time.
Right?
So I want to thank you both for a great discussion and really an exciting one about where we're going, and congratulations to both of you for what you've done
Yes, that's
in
really good
Norwalk
work.
and are extending to Danbury. When we come back, we'll have today's health question.
Right now, let's take a look at some of our upcoming events sponsored by Western Connecticut Health Network. This week's viewer question is, how can we find out more about community resources available in Connecticut?
So Rowena, Tate, somebody's at home with a loved one, or they themselves have these kinds of problems, substance abuse, et cetera. How do they get resources?
Well, one easily remembered way and a good way to access care is through 211. And so that Connecticut is
This
now
is dialing on the telephone.
dialing 211
211
on the
Okay.
telephone.
And what happens when you do that?
So you'll get an operator, and you can talk about everything from, not feeling like you might harm yourself. So they can talk, send you to a hotline, or housing issues, or issues with your electricity bill. I mean, it's a huge.
So the
range of
operator can
information.
direct you to somebody then?
That's correct. And then the other thing is the website. So the 211 website is very complete.
What is the URL for that, the address?
I think 211.
Okay, we should have known that for this show.
But there are a lot of
Google 211
If
Connecticut.
211 Connecticut will absolutely get you there.
But there are a lot of community resources that 211 helps you tap into, something like a
Absolutely.
number of different agencies, correct?
And it's
So-
also good for providers of care, too. It
Yes.
was really interesting when we were doing the community health needs assessments. We identified that people might be working with the same population, but they didn't know about each other.
Yeah.
And a lot of provider offices say, where do we go if I have a child who needs help, mental health
Yeah.
issues, where do I go? It's also good for providers
So we
to-
should
to-
make sure that providers know about the
That's
211 number just as
So
much as patients.
providers themselves can call 211.
That, absolutely.
We've got 30 seconds left. If somebody wants to get their relative or themselves into this community assessment group and they live in Norwalk, the Norwalk area, is there any way they can do that?
Well, there are a couple ways. The Norwalk Department of Psychiatry is always accessible, so you can call
They
the
call
main
that
number
through the
here.
hospital?
Yeah, through the main hospital, and we have
That's 203-852-2000.
2000
Yeah.
or 203-852-2988, and there's a wide range of services available there, and that can also be a point of contact.
Okay, so we've
Great.
given two ways for people to gain access. It's 211 or calling Norwalk Hospital. In the Danbury Hospital, can they call Danbury Hospital for the same thing?
Absolutely.
Great. Thank you both.
Thank
We've
you.
run out of time.
Thank you.
Thank you.
If you have a question at home that you'd like to ask on Health Talk on TV, please contact Vicki and me at healthtalk@norwalkhealth.org.
Eric and I would like to thank our guests today, Rowena Bergman and Dr. Tate Michael, for coming on Health Talk.